Okay, hi, this is Elliot Fishman, and hopefully I am live and I'm screen sharing. And this is our monthly third Thursday where we do a CT quiz where I share some of the cases I recently quizzed our faculty and fellows on and some additional cases. So here's a patient with hematuria, and if you look quickly, there's a mass in the left kidney, renal cell carcinoma, next case. But if you look really carefully at the mass, you'll notice that there's a little dot here. And if you measure that little dot, it measures minus 55 Hounsfield units. Now, we know that renal cell carcinomas theoretically can contain fat, but usually it's macroscopic fat and it's very aggressive tumors invading the peri and pararenal space. This is a vascular lesion which has an area of fat within it. Here is, you can see a little bit, maybe a tiny AV shunt within the lesion. And then here it is in the non-contrast. That little low-density zone measures minus 70. And what should I be thinking about? Yes, your solid mass looks like a renal cell, but with a little dot of fat, you got to say to yourself, could this be a lipid-poor angiomyolipoma that only has a small amount of fat present? And that's what you got to think about. It's a great case. Imagine, if you're thinking of partial nephrectomy in this patient, or if you knew for sure this was an angiomyolipoma, you might leave it alone. But this was a myelolipoma. Again, a little bit of fat. One of the most common reasons patients get partial nephrectomies or nephrectomies for masses that are benign, still over 20% of cases, is because of lipid-poor AMLs. So kind of a great case. So it's a really, really nice example. Okay, next case, hematuria. What you see here is multiple masses in the kidneys bilaterally, and there are multiple areas of macroscopic fat present. You can see the kidneys are fairly vascular, particularly the left kidney. And what we're looking at really is multiple fatty tumors and non-fatty tumors. And when you have multiple fatty tumors, multiple myelolipomas, you have to think of a syndrome, which is tuberous sclerosis. Another thing that can be helpful in making the diagnosis is tuberous sclerosis has bony osteomas. And so if you look at the S1, S2 level, you can see a sclerotic lesion. That's an osteoma. And this was multiple angiomyolipomas with osteomas in a patient with tuberous sclerosis. Okay, really great case. Another case. Abdominal pain, huge mass in the abdomen, all the bowels displaced. This mass is a fatty attenuation. So sticking with that fat, AMLs, this is surely not a giant AML. This is a large retroperitoneal mass displacing bowel, displacing vessels, very classic for a liposarcoma, which is the most common retroperitoneal mass. Liposarcomas can invade the kidney. Sometimes giant AMLs can be confused with liposarcomas. What about this case? Sticking with the kidney, weight loss and hematuria, you see a large infiltrating tumor by the left kidney, extensive disease in the peri and pararenal space, involvement of the left psoas muscle. There's also disease by the pancreas and retroperitoneum. Well, this is not the look of a liposarcoma, and this is not the look of a renal cell carcinoma. There's infiltration of the kidney, but the para and pararenal spaces are involved. And there's also involvement of the contralateral right kidney to a lesser degree, and the area near duodenum. So what are we thinking about? Vessels are encased. This is a good example of lymphoma. Lymphoma has many appearances, maybe 5 or 6, in the kidney, from single solitary mass to multiple masses to diffuse infiltration, unilateral or bilateral, and then also involvement of the peri and pararenal space. Sometimes melanoma can simulate this, but usually when you have such bulky peri and pararenal space, you're talking about B-cell lymphoma. Okay, next case. Patient with hematuria. You see a mass vascular in the left renal hilum, and that's a renal artery aneurysm, and that may be the source of the patient's hypertension. But look at the right renal artery. Look at the beating. So there's beating in the right renal artery. There's an aneurysm of the left renal artery. Just a beautiful example of beating. What is the disease that gives you beating? Well, that's fibromuscular dysplasia, FMD. FMD can involve the kidneys and carotids. Those are the most common. We see it not uncommonly in the iliac vessels, in the SMA, but renal and carotid is what you typically learn about in the books. Beautiful example, MIP, volume rendering, all show it nicely. And in FMD, you can see stenosis, you can see aneurysms and beating. And this case gives you all of them. Great case of FMD. Another patient, adrenal mass, calcifications and some fat. I looked at this and say calcifications and fat, it's a myelolipoma. When you look at the lesion, when it enhances, it's not very vascular. A little bit of peripheral enhancement. The kidneys function normally. There's a hemangioma in the liver. What could this be? It doesn't quite look like an ACC, but also that macroscopic fat and calcifications to me as a myelolipoma. Patient had no history of primary tumor or anything else, or no symptoms, no hyperfunctioning symptoms. Blood levels and urine for Theo were normal. So what do you think about? Well, when I looked at this case, I thought it was a myelolipoma of the adrenal. Yes, we see lots of fat usually, but some are lipid poor, and they have some fat, like you can see here, and punctate calcification. The pathologist read this as an adrenal cortical adenoma with prior bleeding, and it's hard to argue that, but you don't see that macroscopic fat in adenomas. And remember, when pathologists look at tissue, they're looking for malignancies. They don't section every section, and the fatty component was very inferior. So that's the official diagnosis. I think the real diagnosis was a myelolipoma that was resected. Abdominal pain, thickened gastric folds, really, really impressive. You can think about lymphoma, really bad gastritis. You could think about a polyposis syndrome. You could think maybe the patient has a MAN syndrome with a gastrinoma and multiple carcinoids in the patient's stomach. But if I told you those are all good possibilities, but this is benign, there's no malignancy, what else? The world's worst case of gastritis, I guess that's a possibility, but these folds are so large. There's an entity that you used to look at fluoroscopy, and they'd quiz you on boards, and that's Menetrier's disease. And by the way, there was an incidental oncocytoma in the kidney. Very large, thickened gastric folds. Really, really impressive. Most common, it's going to be in the fundus. Really, patient with down with epigastric pain. So thickened gastric folds, yes, malignancy, you got to think about polyposis, gastrinoma, but Menetrier's is something to consider as well. Now, abdominal pain, you see about a 2 centimeter vascular mass in the body of the stomach, very nicely shown right there. And we look at it on coronal views, you can see it's a flat lesion. There's vascular liver lesions also present. So what am I thinking about? Well, you can get glomus tumors in the stomach, vascular. You can get ectopic pancreatic arrest, but that would not explain a vascular liver lesion. It's not the appearance of an adenocarcinoma. Just can be small and they can be vascular. I guess that would be a theoretical possibility, but more likely a flat tumor, vascular, you got to think about a carcinoid in light of the liver, and this was a gastric carcinoid. A really, really nice case. Now, what about this patient? Abdominal pain, nausea, and vomiting. Why you always look at the sagittals is shown in this case because there's narrowing of the angle between the SMA and aorta, and the distance is decreased. When you look at the patient's stomach, it's well distended, but then the duodenum is distended. You see the angle and compression of the left renal vein again. But look at the duodenum as it comes across, it's dilated, and it changes. Transition point is where the SMA is. Remember, two things go between the SMA and the aorta. That's the left renal vein. It gets compressed, so you have nutcracker phenomena. And You get duodenal dilatation because the duodenum is compressed, and so proximally you have the duodenum dilated. You can have the symptoms of gastric outlet obstruction, and these are the findings in SMA syndrome. Now, it's not uncommon for us in thin patients to see narrowing of the SMA to aorta angle and the distance decreased, but for me to call SMA syndrome, I need to see duodenal distension, which I did see in this case, and so I made that diagnosis. Chest pain, anterior mediastinal mass, eccentric. You got to know the patient's age, that'll affect the differential, but things to think about: thymoma, teratoma, lymphoma, metastasis. Solid and eccentric, I always got to think about thymoma. Usually patients are in their 40s, but the other possibilities would still be the differential diagnosis, and this was a thymoma. So think of that case, and then think of this case. Here's another mass, but it's a little bit lower. It's eccentric. It's cystic with some layering. Could this be a duplication cyst that bled at some point? That's a possibility. Could it be a cystic thymoma, low lying? That would be a possibility. Could it be a teratoma? Some material within the lesion? That would be a possibility. Pericardial cyst, in theory, pericardial cysts can be large and they can bleed or have some proteinaceous material, so you couldn't exactly rule that out. Here it is nicely shown in the coronal view. Really good location for a pericardial cyst, not a great location for a bronchogenic cyst. This was eccentric and low-lying, and this was a teratoma. Teratomas can be cystic, have solid components, have calcification, be vascular, but it's unusual. It was so low-lying that teratoma wasn't probably the first thing you thought about. So that's more than a dozen cases, or around a dozen cases. I hope you got them right. I hope you enjoyed those cases, and I hope you have a terrific day. And it's warm out, and we're working. See you later.